my mentors in public health, my mentors in clinical pulmonology, and my mentor in research. So I'm pleasantly privileged to be here. And ladies and gentlemen, I'll be just briefly talking about a topic that is burning hot right now in the world. DRTB, drug-resistant tuberculosis. And what has happened during the last 5 years? The one thing that I want to mention is, we know about this slide, that Pakistan has 258 per 100,000 cases. All right, thank you. And we have more than 600,000 TB cases, drug-susceptible TB cases every year. MDR-TB, we have 15,000 cases every year with 6.2 per 100,000 population. 2.3 new cases and 4.6% MDR-RR-TB in retreatment TB cases. This is a very important slide, and I'd like you to have a look at it, because we started a programmatic implementation of DRTB in 2010 with 3 PMDT sites to work. Right now, we have more than 65 DRTB sites in Pakistan looking after and providing DRTB care. And by 2026, under the leadership of Common Management Unit, we will be having a triple one, a single Nelson's, in 2026 DRTB care sites. That's a remarkable achievement of the Common Management Unit and National TB Control Program in collaboration with Pakistan Chest Society. And why I'm saying Pakistan Chest Society? That Pakistan Chest Society, Dr. Shah and Professor Arshad, you would remember that the first guidelines in 2009 was developed by Pakistan Chest Society and National TB Control Program together. So, I mean, while I stand and talk here, I feel very confident. I feel at home that I'm talking to a group of people, listeners, who are treating MDR-TB every day. They come across DRTB, RRTB every day. And we started the 229 cases in 2010, but now we have more than around 4,000 cases diagnosed in DRTB. I won't go into detail because of the time limitations. Lekin, all of you know that in 2010 till 2017, we have treatment of 24 months. Injectable, emacracine, and so many which you know very well. I won't go into that detail. But now, I mean, the new things came in. Bedaquiline came in. After 50 years, after rifampicin, the first anti-TB drug after 50 years was bedaquiline. The rest was repurposed drugs. Then we had short treatment regimen. I won't go into these details because it's going to take long. We had injection-based short treatment regimen, as we got Bangladesh study. Then we had long treatment regimen, oral long treatment regimen. I mean, these were, and the point that I want to highlight is to Pakistan, my colleagues of Pakistan Chest Society, that National TB Control Program, under the leadership, I mean, we were the first in the whole EMRO to adopt new WHO guidelines, be it bedaquiline, be it short treatment regimen, be it all oral treatment regimen. But, I mean, things have changed in the last 5 years in DRTB management. Evolution of diagnostic tools and revolution in DRTB treatment. Next trials हुई, Xenix TB trials हुई. उन्होंने बताया evidence, unequivocal evidence that 6 months treatment of bedaquiline, predominant, and linezolid will treat drug-resistant TB with additional resistance to fluoroquinolone. Pakistan, unfortunately, is a country, sir, ladies and gentlemen, which have more than 30% enrolled cases as fluoroquinolone resistant with poor outcomes. So we were watching this, we were waiting this, that there should be a combination package or regimen that can address DRTB with fluoroquinolone resistance. So we were again the first in Pakistan to adopt to this, and you are all, most of you are managing DRTB, and you look after PMDT sites are aware of that. लेकिन उसके साथ निक्स टीबी, जीनेक्स टीबी और साथ ही टीबी प्रैक्टिकल अनइक्वोकल एविडेंस के साथ आया कि अगर आप इनके साथ मॉक्सीफ्लॉक्सासिन देंगे बी पैल के साथ तो ड्रग ससेप्टेबल टीबी क्योर होगी। अब 9 से 11 महीने की कहानी थी एक वक्त में सब शॉर्ट ट्रीटमेंट रेजिमेंट, वी आर वेरी हैप्पी। 18 to 20 months रेजिमेंट थी, और अब हम बात कर रहे हैं 6 महीने के इलाज की। WHO की रिकमेंडेशन आई जी बी पैल ये जीनेक्स ट्रायल्स के बाद और प्रैक्टिकल के बाद उन्होंने बताया कि बी पैल 6 से 9 महीने में क्योर होगी, और बी पैल एम मतलब सेंस वो 6 महीने में क्योर होगी। और उन्होंने साबित किया और ये रिकमेंडेशन भी दी कि दोज हु डू नॉट फिट इन हियर कैन हैव 9 months ऑल ओरल शॉर्ट ट्रीटमेंट रेजिमेंट। DRTB ट्रीटमेंट ऑप्शन राइट नाउ हमारे पास क्या है जी? I need your attention, aware of the time. अगर बी पैल है मतलब अगर ड्रग रेजिस्टेंस टीबी है विद FQ रेजिस्टेंस तो आप बेडाक्विलिन, प्रोटोमिनेट एंड लैंजुलेट के साथ यू आर ओके विद इट फॉर 6 to 9 months ट्रीटमेंट। और अगर आपकी ड्रग MDR-TB है और ड्रग से आपके पास FQ सेंसिटिविटी है तो यू कैन गिव 6 months ट्रीटमेंट and cure the patient with B-PAL, with moxifloxacin. Oral short treatment regimen, इसके बारे में I won't go into detail, we all know about it. This is a Bangladesh study, much mentioned, much followed, much practiced. And all oral long treatment regimen is our last option now. This is the last option now. This should be the last option now. While we are having so effective regimens above, there is no point in putting the patient on 20 to 24 months treatment unless required. BPAL के बारे में बात करूँगा जी, बाकी I won't go into the detail in the interest of time. BPAL हमने शुरू किया. I'm sincerely very thankful to Dr. Razia because as an advisor and a researcher, she was very much into it that we should start this regimen, and luckily we did. WHO recommendation आई, we promptly revised our training material. सबसे अहम बात जो इस वक्त थी ladies and gentlemen कि प्रेडोमिनेंट बहुत कम थी, तो हमने उसको एक्सेस किया और इस वक्त 1 जनवरी से all our sites are using BPAL M regimen. I won't go into this. I'll just share this a very important slide with you. And during the 2022 and 2023, we enrolled 463 cases on BPAL M. And 431 cases completed the treatment. How many? 431. And what 400 cases were successfully treated. Treatment success rate was 92.8%. It was 93% of BPAL M and 92% of BPAL. I just want to draw your attention to one thing. When we treat DSTB, we treat it for 6 months. And we have a treatment success of 92%, 93%. Now we are treating DRTB with FQ resistance, and we are having more than 90% success. So this is something that we need to do, we must do, and we do with all the precautions, with all the inclusion, exclusion criteria keeping in view, with all the side effects keeping in view. If we don't do that, we might lose a very important combination regimen. एक बात जो मैं ज़रूर कहना चाहूँगा कि प्रेटोमिनेट cannot be given alone or any other combination. Pretominate can only be given with bedaquiline and lanzolate with moxifloxacin or without moxifloxacin. But pretominate cannot be an independent drug in any other combination. That's what WHO recommends. I'll come to this as my final slide. I missed out on many slides in the interest of time. But one thing that we need to do is, if we are doing the DRTB management or DSTB management or BPAL, the most important thing that we need to do is monitoring, side effect management. patient's health is supreme. We know the lens-related side effects. We know myelosuppression. We know about neuropathies. We are aware of QT prolongation. Keeping all that in view, we should have a robust ADSM mechanism in place so that in the time to come, our patients are treated within 6 months' time. Way forward, kya hai ji ke? Okay, I get you. The development of care-responsive, digitalized ADSM. That's what I'm emphasizing again and again. Drug safety managing and monitoring is paramount, is fundamental. If we don't do that, we are going to compromise a very, very important regimen. And with that, I thank you very much.
Thank you, sir. I have an announcement to make that all the PCS-sponsored PGRs, they should mark their attendance outside. I welcome Professor Colonel Muhammad Amir for inclusion in the panelists. Sir, thank you very much. The next presentation is from Dr. Asad Zaidi. He is the graduate of Aga Khan Medical University, and he has published many high-value articles, including Lancet. He is affiliated with University of London, and his present